Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Approach to Adnexal Mass, Adolescence to Senescence, organized by TNFOG and Madurai OBGYN societies. So it's my privilege to introduce the embassy of today's webinar, Dr. Radhika Gauri ma'am, specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good evening, esteemed faculties, and it's a great privilege to be among you as an MOC. Thank you, Padma ma'am, for the opportunity, and thank you, Vidya ma'am. So today's topic is this Adnexal mass, and it's very important one because nowadays, due to the advent of all the investigations like MRI, easily we are able to look at the Adnexal masses and treat them accordingly. So in this episode, let's listen to the faculties and enrich our knowledge. I request Padma ma'am and Vidya ma'am to give an introduction and welcome all our faculties.
So it gives me great pleasure as a convener of this TNFOG Oncology Committee to call for this meeting. And we all understand that Adnexal mass is a very important clinical problem and it baffles many clinicians. So whenever a patient presents with an Adnexal mass, irrespective of the age, first thing is we are worried, we are concerned whether it is a benign, malignant or a functional mass. And based on that, should we wait so that the functional mass disappears or should be operate? And if it is operate, we are worried whether, we are concerned whether it is really benign or there is some malignancy lingering on, and who should operate, how to operate, whether we can do it minimal access or we should refer it to a gynae oncologist for proper evaluation and treatment. So all these things run in our brain. So that is why I thought the best person to address this will be Dr. Abraham Pedicale, a renowned gynae oncologist from CMC Vellore and now practicing in Vellore Narvi hospitals. And today I welcome our chairpersons, Dr. Lakshmi Seshadri. Lakshmi Seshadri madam, almost one full generation of us have studied her books, especially for practicals, and then we have given and passed our exams. And she's a gynae oncologist herself, initially with CMC Vellore. Welcome you, ma'am, for this webinar. And the other chairperson, Dr. Vani Mohan ma'am, she was a professor of OG in Coimbatore Medical College. And a special word about ma'am. She's very close to my heart, and she was the one who was an inspiration for me to take up OG. Thank you, ma'am. Thanks for that, and thanks for joining today. And I request our president, Vidya ma'am, to say a few words.
Yeah, thank you very much, Dr. Padma. And good evening, Lakshmi Seshadri ma'am and Dr. Vani Mohan ma'am. I think I'm extremely happy to be here. Actually, what I find is Dr. Padma is extremely enthusiastic and she's so diligent about all these monthly meetings. And every time she brings a fresh topic and, and very good speakers for that. Like today also, she's brought in one of the excellent speakers and absolute authority on the subject. Actually, I really congratulate you, Dr. Padma, for taking this initiative. Every time you do a very good job. And I find that absolutely there are a lot of people. In fact, I'm part of many webinars, and I find that this particular webinar is always well attended. Always, I find that initially you will be finding like 14, 15 people, but then in the due course of time, you will find that there are at least 100 people joining this particular session. That is a minimum that I see every time. And I think that is the credit goes to you because of the topics chosen. Like today also, the topic is excellent topic because Adnexal masses are something we all encounter, and it is not something like you will immediately, pass it on to somebody. Like there's some general gynecologists will be passing it on. But adnexal masses, the moment when you see, like you are in a dilemma and you have to deal with it. So it will be of benefit to all the general gynecologists as well. It's not just who are focused on oncology or anything. And so that way, this topic should be of interest to all the gynecologists. And thank you very much for choosing this particular topic. And we have excellent chairpersons today. Both of them are having so many years of experience. And as you very rightly said, we've been reading their books and all that. Lakshmi Seshadri ma'am's books and all, very famous. And I actually somehow I was unable to invite her to Salem. I think next time when we are doing the conference, madam, you are going to be here. So we want you here. We will be calling you definitely. And and now we have the excellent speaker with us. So I think the stage is all yours. Thank you very much.
So Radhika can introduce.
Sure, ma'am. It's a privilege to introduce Dr. Lakshmi, ma'am. She's a former professor at HOD, Department of Obs and Gynae, CMC Vellore, and former senior consultant, Obs and Gynae, Thirumalai Mission Hospital, Ranipet, Vellore. And she has more than 50 publications in index journals, and she's written numerous chapters in textbooks. And the main one is the Essentials of Gynecology, 2010, 2016, and 2022, and Essentials of Obstetrics in 2015 and 20. Several orations awarded in various conferences, and her area of interest, gynae oncology, menopausal medicine. And she has done numerous community work she's involved in, and screening for cervical cancer with via are more than 9,000 cases, and screening and management of non-communicable diseases in a rural population. We welcome you, ma'am. And we welcome Dr. Vani Mohan, ma'am, who is a senior consultant obstetrician and gynecologist, women and child care. And she worked in government PHC, ESIC dispensary, Coimbatore Medical College in a hospital. And she's a rank holder in DGO and University First in MD with Sir A.L. Mudaliar Prize. And she's delivered speeches in several social forums. And she's a member of OXY, COXY, and IMA. Welcome you, ma'am. Then we have our speaker, Dr. Abraham Pedical, sir, who is an MBBS, DGO, MD, MPH fellowship in gynae oncology, senior consultant gynae oncology, Naruvi Hospital, Vellore, and he is the past president of AGOI and AOGI in India, and senior consultant in. He's worked in Muscat, Oman, and professor and head of the gynae oncology department in CMC Vellore, India. And also, he is a member of SGO, IGCS, and IAGE and FOXY. He has more than 110 publications. We welcome you, sir. And we are very eager to listen to your lecture, sir. Thank you.
Do I start screen sharing? Dr. Lakshmi, chairperson.
Yes, I think so. I think if all are eagerly waiting for the presentation, Dr. Abraham.
I hope I can do justice. I'm feeling nervous with all such senior people here. And it's good to have my teacher, Lakshmi Seshadri, here. Trying to share my slide.
While you are sharing your slide, just want to add that the problem with the ovarian cancer now, I think with an Adnexal mass is an overdiagnosis because of routine ultrasound scan for the smallest or the fiftieth of reasons. And then people wondering what to do and embarking on the wrong kind of treatment because they're not very sure of the approach. And I think that is what you're going to throw light on today. Abraham, the stage is all yours.
Can you see my?
Yes.
Can you see my slides?
Yes, we can.
Okay, thank you. President Dr. Vidya, Sampath Kumari, Dr. Shravana Kumar, Dr. Padma for calling me, Dr. Chairpersons, Dr. Seshadri, Lakshmi Seshadri, Dr. Vani Mohan, and the MOC, Dr. Radhika.
Thank you.
I am talking on a very clinically relevant topic, and I've titled it, short title, Evaluation of Adnexal Masses. I'm not going to too much of the treatment. And as a background, adnexal masses are quite common clinical problem. 20% of premenopausal women, 10% of postmenopausal women do have adnexal masses, and they may arise from the ovaries, tubes, or even other nearby structures. And women may present for varied reasons. Now, this is always at the back of my mind, and I suppose I'm biased as an oncologist, but ovarian cancer is relatively uncommon but lethal, and affecting about 3% of all cancers and comprising 3% of all cancers in women. And the appropriate management of the adnexal mass depends on the type of the mass. So the presentation of these the masses, quite often they are asymptomatic and discovered during a master health checkup or after abdominal pelvic scan for some other reason. And now with so much of imaging, routine ultrasound scans pick up these masses. They may be symptomatic with pain, urinary frequency, vomiting, change in bowel habits, pelvic pressure, discomfort, or even abnormal bleeding. And the mass may be palpated by abdomen or during a vaginal examination. And sometimes they're discovered at surgery. Now, the goals of evaluation are to determine the origin of the mass, to determine the nature of the mass, to determine if there's an emergency, if something has to be done immediately or not, and to decide on the appropriate management. So the adnexal masses could be cystic or solid, simple or complex, unilateral or bilateral. Most are benign, so that's something to be kept in mind. And the diagnostic goal is, however, to rule out malignancy. Now, there are some worrisome masses, those that have complex internal structure, solid areas, thick septae, masses that have increased blood flow, masses in prepubertal girls and postmenopausal women, because the risk of malignancy is high in these age groups. Masses that cause pain, loss of weight, anemia, or hemodynamic instability need to be tackled fairly quickly. Now, the differential diagnosis, of course, when you talk about an ovarian mass or any adnexal mass, full bladder has to be emptied because many an ovarian cyst has disappeared into the K basin. And of course, tuberculosis is common in our country. Abdominal wall tumors, hematomas, mesenteric cysts, hydatid cysts, paraovarian cysts, retroperitoneal tumors, GI tumors, including gastrointestinal stromal tumor. And if you're suspecting a secondary ovarian tumor, then we need to search for the primary. And this is a situation when there are bilateral, solid, mobile tumors. So like I said, there's a long list of possibilities. Here I've divided them into gynecological and non-gynecological, benign and malignant. Give you a minute to go through the slide. I'm not going to read out each of them. And probably there are more that could be added. I think all the senior people here would probably have seen all of these. And I, for myself, from one, have seen most of them, except I think urethral diverticulum. These things go, of course, go to the urologist. Now, the evaluation of adnexal mass, we start with the history. So important, the symptoms, the menstrual history, the gynecologic and family history, the investigations and treatments that these women have already had. The clinical examination would be, general examination, the pulse, the icterus, supraclavicular node, breast, systemic examination, speculum, per vaginal, per rectal examination. The primary imaging modality should be ultrasound, both trans-abdominal and trans-vaginal could be used. And secondary imaging is only CT and MRI. PET scan really has no place in the primary evaluation of an adnexal mass and is really reserved for the recurrence of cancers. Now, the guides to categorize these adnexal masses: one, age of the patient, the reproductive status, history, including the family history, the symptoms, as we mentioned, physical findings, the anatomic location, imaging, blood investigations, including serum markers. Now, how does age of patient help? Less than 9 years, the prepubertal, 80% of ovarian masses are malignant, and usually these are germ cell tumors. In the adolescent age group, 50% are dermoid cysts. If there's a Y chromosome present, then 25% of these masses are malignant and usually a dysgerminoma. Of course, endometriomas and TO abscesses are possible. And if there is pain, it could be an endometrioma. If a girl is sexually active, you have to think of a TO mass. Now, 18 to 45, the reproductive age group, again, dermoid cysts are the most common, but you do get endometriomas, and 10% of masses in this age group are malignant. Above 50 years, that's the postmenopausal group, about 25% are malignant. Now, you could get an adnexal mass in pregnancy. It's more than in the general population because all the antenatal ultrasounds pick up these cysts. Many of them are functional cysts. And up to 20% of pregnancies do have an adnexal mass. And these are functional cysts, dermoids, endometriomas, cystadenomas, and for the most reason, they are benign. Most of the time, they're benign. Malignant cysts could be seen in about 5% of cases in this age group. Now, the risks of these masses, of course, have torsion, hemorrhage, infection, miscarriage, preterm labor, malignancy. And benign masses can be left alone. Symptomatic and suspicious ones need surgery, and laparoscopy should be offered if possible. Now, the history helps in differential diagnosis. For example, pain, amenorrhea, vaginal bleeding, positive pregnancy test, think of ectopic. So, severe pain associated with nausea, vomiting, maybe some guarding, ovarian torsion. fever, nausea, emesis, purulent discharge, you think of PID and TO abscess. If it's severe dysmenorrhea, dyspareunia, abnormal bleeding, it could be an endometrioma. And premenoptical and postmenopausal bleeding, you think of a granulosa cell tumor. Now, family history is important, and this overall about 10% of ovarian cancers are hereditary. And we have to think of the hereditary breast ovarian cancer syndrome, where the BRCA1 and 2 genes are mutated, where the ovarian cancer risk goes up to considerably. And then you have the Peutz-Jeghers syndrome, the Lynch syndrome, Fanconi's anemia. Again, the cancer risks are more than the general population. Now, when we assess the symptoms, you ask for these, do you have pain in your abdomen, pelvis? If it's yes, then you ask them how frequent, how long have you felt this way? And similarly, do you feel full quickly, or are you unable to eat normally, and so on? So for each of these questions, you ask them the frequency and the duration. Now, Barbara Goff from Seattle came up with this logistic regression analysis to show that when these symptoms were present for significant duration and significant frequency, then it's more than almost 20 times more than the general population, the risk of malignancy. Of course, laboratory tests do come in. We always start with the CBC, hemoglobin, to see whether it's anemic, creatinine, pregnancy test, if in the reproductive age group, CA125, and all postmenopausal women with an Adnexal mass. In premenopausal women, CA125 should be done if the ultrasound shows a suspicious mass. And of course, the primary modality should be a mode grayscale ultrasound. Now, these are the ACOG referral guidelines. So in premenopausal women, elevated CA125 more than 200, ascites, evidence of abdominal or distant metastasis, family history of one or more first-degree relatives with ovarian or breast cancer. And in postmenopausal women, the CA125 more than 35, nodular or fixed pelvic mass, ascites, evidence of abdominal or distant metastasis, family history, if significant. Now, ovarian tumors could arise from sex cord stroma, the germ cells, and surface epithelium, as shown in here. We have the different types of ovarian tumors. And these could affect different age groups, different presentations. Now, the epidemiology of ovarian cancers, the lifetime cumulative risk is 1.4%, that is 1 in 70 women. And it is the second most common gynec cancer in the developed world. And even in India, because of the referral bias in the tertiary center, this is probably one of the most common tumors that gynecologists see. The mean age is 58, but really there are twin peaks at 15 and 65. And of course, the risk factors would be family history of breast ovarian cancer, nulliparity, no mutation carrier. The symptoms of ovarian cancers whisper, so we need to pay heed. The symptoms are sometimes not very striking, but they may complain of bloating, loss of appetite, early satiety, loss of weight, urinary urgency, frequency, abdominal distension, discomfort, constipation, changes in bowel habit. So like in the Goff symptom index, we need to ask whether the duration and the frequency. The clinical findings of ovarian cancer: cachexia, pallor, icterus, edema, supraclavicular node, pleural effusion, dilated veins, the umbilical nodule, Sister Joseph nodule. Sister Joseph was the matron of the senior Mayo, Dr. Mayo at the Mayo Clinic in Rochester, Minnesota, where I did train. They may present with an omental mass or abdominal pelvic mass with ascites, and on vaginal examination, you find the nodularity in the POD, Bloomer's shelf. Rectal examination is very important. Now, screening for ovarian cancer we have the symptom index, the pelvic exam, tumor markers, ultrasound, multimodal screening, but really in low-risk women, there's no role for screening. Most of the societies would say there's no role for screening. Low-risk family history, again, no screening. It's only when you have a very high risk family history, especially if there's a mutation in the family, then you could probably screen them. That too, if they have not had an RSO. Now, what are the tumor markers that we have to deal with? One is for suspected epithelial ovarian cancer. We have the CA125, CEA, and CA19-9. I don't use CA19-9 unless there are strong GI symptoms. The CA125 to CA ratio in ovarian cancer should be more than 25. The suspected granulosa cell tumors, we could send INHBE B or AMH, and suspected germ cell tumors, you have AFP, beta HCG, and LDH. So this gives a little more detailed of all the hormones or the tumor markers, as well as the various types of germ cell and sex-cord stromal tumors. For example, in this dysgerminoma, you have alpha-fetoprotein, HCG, LDH, predominantly LDH, but these are sometimes non-specific markers, so we have to take the whole picture into consideration. In choriocarcinoma, of course, beta HCG would be the most important marker, but we could get LDH elevated as well. In certainly Leydig cell tumors, you could get mild elevations of AFP, estradiol, inhibin, testosterone, androstenedione, DHEA, and so on. Now, for elevated CA125, like I said, some of these tumor markers are non-specific. So it may be raised in cirrhosis with or without ascites, disease involvement of a serosal surface, endometriosis, pelvic inflammatory disease, tuberculosis, and the level may be in the thousands. It's not that it's only moderately elevated. And of course, malignant conditions for breast, lung, endometrial, cervical, GI, pancreatic cancers all could have. I recently saw a patient with cervical cancer with a lot of peritoneal disease, where the CA125 was almost 2000. Up to 1% of women have elevated CA125 that fluctuate during the menstrual period. So if they have retrograde menstruation, that also can lead to a rise in CA125. Now, I said that B-mode grayscale ultrasound is the primary modality, so it's pattern recognition. So you look at if it's a simple cyst, thin-walled, uniloculated, no solid areas, we say it's a simple cyst, maybe a functional cyst. Dermoids, they have their own characteristic appearance because of the fat and the sebum, the hair. And the endometriomas, you have the ground glass appearance. Peritoneal pseudocysts might present after surgery or after infections. Para-ovarian cysts, you should see a normal ovary next to the cyst. And hydrosalpinx, you see the typical shape of the tube as well as the septate. Now, this is just may not be very clear, but complex cysts like dysgerminoma, it's solid on cut section, and you see a lot of blood flow. Similarly, yolk sac tumor, again, you see mixed echogenicity and blood flow. Now, ovarian crescent sign has been described. So this is a simple cyst in a 57-year-old post-menopausal woman, and the normal ovarian tissue is seen on one side at the periphery, and that is known as the ovarian crescent, where the white arrows are indicating it. So this is a sign of a benign cyst. Now, the appearance of a dermoid, all these signs have been described: tip of the iceberg sign, dot dash or dermoid mesh, mixed echogenicity, fluid levels, coins in a sac, or the boba pearl sign. So basically, it's because of the hair, the fat, and the other fluid that is there. And sometimes there may be some calcification as well. Now, ultrasound, Deep Priest was one of the first to come up with a scoring system. So he gave points for 0, 1, 2, 3, and 4 for volume, cyst structure, and septal structure. And he said if there was a score of more than or equal to 5, there was a positive predictive value of almost 45% for malignancy. There was a Uland or Kentucky Morphology Index, again looking at only volume and the pattern. Look at whether any solid areas, whether any septae, the thickness of the solid areas, the number of solid areas, and so on. And you give points 0 to 5, so you get a maximum of 10. So the maximum score is 10, cutoff is 5, sensitivity 95%, specificity 80%, positive predictive value 40%, negative predictive value 99%. Now, we've all heard of the risk of malignancy index developed in the 90s in the UK and it's been modified several times. It combines ultrasound, CA-125 level, and the menopausal status. And if the RMI is more than 200, it should refer to a specialist. Ultrasound is scored 0 to 1 or 3. Menopause is 1 or 3, and actual CA-125 level. Because of the 0, sometimes even if there's a menopause, post-menopause, or the actual CA-125 level could be negated, so then the modifications took off the 0 and made other changes in the scoring. But all of them actually work almost the same. See, RMI 1 and RMI 2 are considered good, but they really almost all behave the same. Now, OVA1 is a multivariate index assay, 2 upregulated proteins, CA-125-2 and beta-2 microglobulin, 3 downregulated proteins, transferrin, transthyretin, and apolipoprotein A1. And the software combines the results of all these 5 assays to give a numeric score. So in premenopausal and postmenopausal women, the cutoffs are a little different. So it gives you a low probability of malignancy and a high probability of malignancy. They're not usually done. ROMA is the risk of malignancy algorithm. It's approved in 2011 by the FDA. It combines CA-125 and HE4. Again, a logistic regression algorithm that gives a ROMA score. Premenopausal women and postmenopausal women, the cutoffs could be different. And this is one study that showed in low risk premenopausal and postmenopausal slightly different cutoffs, 12.5 and 14.4, giving you, picking up 100% of low risk healthy controls, and malignancies picking up 53% in high risk and 46% in the low risk. So you're missing. So if you are in the premenopausal state, you'll miss more than 40%. And in the postmenopausal state, you're going to miss 17.5%. So just shows that when you're doing a diagnostic test, we have to remember that there are 4 possibilities: true positive, true negative, false positive, and false negative. So really there could be a heterogeneity in diagnostic threshold. What do you really want to do? Do you want to more false negatives, or do you want more false positives? So all these continuous measures like CA-125 or ROMA or even blood sugar for that matter, we can choose our own cutoff based on what we are trying to do. So I suppose a generalist would like to have a very sensitive test where if negative, it will rule out disease. And if positive, they should refer to a higher center or a specialist, because you don't want to miss any cancers. Whereas in a higher center, you want to be more specific and less sensitive, because you don't want to start giving chemotherapy or radiation therapy to normal people. Now, ROCA is the risk of cancer algorithm. CA-125 in women without ovarian cancers are decreased with time, whereas the malignancy levels rise. So we've all seen that, as endometriotic cyst, you may have, a CA-125 of 240, and then a few months later, it comes down to 60. And that doesn't happen in a cancer. Again, computer algorithms use individuals' age-specific incidence of ovarian cancer and CA-125 profile over several measurements. And if it's low risk, you repeat after 1 year. If it's intermediate risk, you can repeat in 6 to 8 weeks. If it's elevated risk, you refer for imaging or refer to a center. Now, color Doppler brings out the vascularization. The absence of a tunica media lining results in reduced impedance. So PI of less than 1 or an RI of less than 0.4. But of course, there are problems because location of tumor vessels are variable. Getting the optimal angle of incination is sometimes difficult. It is not very reliable at predicting malignancy, but if you see a lot of vasculature in the solid areas and in the center of the tumor, then it's likely to be malignant. So this is just some pictures showing use of color Doppler. First, you do a B mode evaluation, and on the right-hand side, it looks like a benign simple cyst or an endometrioma. On the left-hand side, it's the suspicion of malignancy. Then you use the color Doppler and you find that blood vessels in the center of the solid area or in the papillary process. Whereas in the benign masses, if at all, it's only on the periphery, not in the center of the lesion. Now, 3D ultrasound is so important both in obstetrics and in gynae. It enhances evaluation of adnexal masses by providing a more detailed view of the mass's morphology and vascularity than traditional 2D ultrasound. Using 3D power Doppler, it can objectively measure and visualize the vascularity within a mass. So these are some of the pictures from 3D ultrasound. Amazing quality of the three-dimensional view, and you can make out, these solid areas or the projections into the cyst cavity. Now we come to the international ovarian tumor analysis, or IOTA models. So from pattern recognition, this group came up with initially simple rules and dividing them into benign, malignant groups. Then they had IOTA LR1, which is a logistic regression model, IOTA LR2, and then finally the IOTA ADNEX model. I suppose, when you're a generalist or in the periphery, you're going to look at pattern recognition and base most of your decisions on ultrasound. But when you go to a bigger center or an academic center, all these different models come in. So the IOTA ADNEX model is good that it can group them into benign, malignant, and within the malignant, they tell you borderline, stage 1, stage 2 to 4, and even metastatic. The IOTA simple rules is basically M1 malignant rules and benign rules. So there are 5 on each side. And if you have several malignant features, then you say it's malignant. And if you have only benign features, you say it is benign. For example, M5 is a very strong blood flow, and B5 is no blood flow. If you take M3, it is at least 4 papillary structures. B3 is presence of an acoustic shadow, and so on. Now, the IOTA LR1 is a very sensitive model. It uses 12 specific variables, such as personal history of ovarian cancer, hormonal therapy use, lesion size, presence of ascites, presence of blood flow. 12 of these variables. And then you feed them into the system, and it calculates for you the probability of malignancy. LR2 is more specific. So here only age and 5 ultrasound features are used. It calculates a score that indicates the likelihood of tumor being malignant. And this can be even used in the periphery by non-expert examiners. The ADNEX model stands for assessment of different neoplasias in the adnexa. And to differentiate between, like I said, the various groups, borderline, invasive, stage 1, invasive, stage 2 to 4, and so on. The model was developed on 5,909 patients from 24 centers in 10 countries. And it also takes into account age, serum CA125, and the type of center. So you have different baseline values for the periphery as well as an oncology center. Because we'll see in a minute. The ultrasound features in the ADNEX model, score of 1 means maximum diameter of the lesion. 2 is proportion of solid tissue. 3 is more than 10 cysts have locules. Yes, no. 4, number of papillary projections. And acoustic shadow. Yes, no. Ascites. Yes, no. So you score them as, on these 5 variables as 1 or 0. Now, this is an example. 48-year-old at an oncology center has a unilocular mass of 6.6 centimeters. As shown here, there is 1 papillary projection, 2.7 centimeters, without acoustic shadowing, or there's no ascites. And the CA125 is 22 units per ml. So most of us would just look at the ultrasound pattern. We might use the M1 and the M and B rules. We might try and use the IOTA rules, LR, L1. But as an example of the ADNEX model, this is what gives you. So it's basically any diagnostic test is a revision of probabilities. When the patient walks into the clinic or starts telling you the symptoms, you have a probability of disease, which is the pre-test probability. And then with each question, with each examination, with each lab finding, with each imaging, modality, the probability is either increased or decreased. So here on the right-hand side, you see the two bars, and the green is benign. So a baseline in an oncology center, somebody comes with a adnexal mass, the chance of it being benign is more than 2/3, that is 68%. And the chance of the adnexal mass, just without any examination or without any test, the chance of it being malignant is about 32%, or including borderline. Now, after the ADNEX model, so we see the revision in the patient risks. The benign from 68 has come down to 59. Borderline has come down from 6.3 to, it's gone up from 6.3 to 18.7. The orange, that is stage 1, has gone from 7.4 to 13.3. The risk of advanced ovarian cancer has gone from 14 to 3, it has come down. The risk of metastatic cancer has gone from 4 to 3, so it is decreased. So from this model, we see that only the borderline and the early ovarian cancer has gone up, but most of the change is in the borderline. And the final biopsy was a borderline serous tumor. So this is how the ADNEX model works. Another example, a 59-year-old at oncology center, CA125 level is 153, solid ovarian mass with a maximal lesion diameter of 6 centimeters, solid component of 6 centimeters, no acoustic shadow, mild ascites, and you can see the color flow. Now, what does the ADNEX model show? The same baseline risks. From 68%, it has gone to 4.7% chance of it being benign. The chance of it being a borderline tumor has gone from 6.3 to 1.6, again decreased. Chance of an early cancer has gone from 7.4 to 67.9. Sorry, 1.6. And the chance of it being a advanced cancer has gone from 14% to 67%. And the chance of it being a metastatic cancer has gone from 4% to 21.2%. So it looks like we're dealing with a malignancy. The question is it a advanced ovarian cancer, or is it a metastatic cancer? Anyway, with this sort of, we need to, patient has to be seen in a specialist, by the specialist oncology team. And the relative risk for the Krukenberg tumor was 5.3. The relative risk for stage 2 to 4 epithelial ovarian cancer was 4.8. And the final biopsy came back as metastatic gastric cancer. Now, the comparison of various models, the year it was developed, the use, and the algorithms, the results. It's a busy slide, and you may not be able to see the small print, but basically we're comparing the various ultrasound models for RMI, IOTA simple rules, IOTA LR1, LR2, and IOTA ADNEX, which is the latest, one of the latest models. So if you look at the IOTA ADNEX, that is the right extreme, it'll, like I said, it tells you the very 5 groups that it could be. And the IOTA simple rules will tell you if it is benign, if it is a benign, B features apply, malignant if only the M features apply. And inconclusive if no features apply or both B and M are there. This is again comparison of different strategies, diagnostic strategies with an ROC curve. See that when you look at an ROC curve, the one with the greatest area under the curve is the better strategy. So here the ADNEX model is the one that's got most of the area under its curve as compared to CA125, which performs the least. And in between we have HE4 and ROMA and RMI. It is not a perfect test. Nothing is perfect. We do have false positives and false negatives, whichever strategy we use. So it is really, we live in an uncertain world. Now, the other system is the O-RADS. RADS stands for Reporting and Data System. So we have O-RADS, B-RADS, T-RADS, and so on, depending on which organ you're imaging. So here you have O-RADS where the risk is less than 1%, and you have scores 0, 1, and 2. And the features are given. Very difficult to remember these things. We need to have it next to the ultrasound machine or the MR machine or on your desk to try and compute the score. And it also links the score to the description of the cyst as well as the management, both in premenopausal and postmenopausal women. So, for example, in this slide, the green one is almost certainly benign. Risk is less than 1%. It could be a simple cyst, different sizes, or it could be a classic benign lesion, or it could be a non-simple unilocular cyst with a smooth inner margin. And the follow-up, the management would be follow-up in 8 to 12 weeks or 1 year, or you refer to a specialist for further imaging. The continuation of the same table. Here the risks are more than 1%. The yellow is 1 to 10%, orange is 10 to less than 50%, and the red is more than 50% risk of malignancy. So if you look at let's look at the yellow. Yellow is unilocular cyst more than 10 centimeters, or if it's looking like a dermoid or endometrioma or a hemorrhagic cyst, more than 10 centimeters, or unilocular cyst with irregular inner wall, or a multilocular cyst with a smooth inner wall but with septations, and so on. And the management would be sent to a specialist or a MRI, or sent for MRI, or you may need to be managed by a gynecologist. And not, see, this is even can be used for people who are not gynecologists, that is the family practitioners or general practitioners. Now, if you look at the red, it's more than 50% risk if it's a unilocular cyst with more than 4 papillary projections of any size, multilocular cyst with solid component of any size, solid lesion with smooth outer contour, any size, solid lesion with irregular outer contour, and ascites and/or peritoneal nodules. Here, you need to send to a cancer center or a gynae oncologist. Now, coming to MRI, conventional MRI gives a pooled sensitivity of about 92%, specificity of 88%. So it's quite an accurate imaging study. And we need to do T1 weighted as well as two weighted sequences. Now, there are different types of sequences in MRI. Fat suppressed T1 weighted imaging to distinguish fat in teratomas from mucinous or hemorrhagic cysts. So they're able to distinguish between the different types of cysts, depending on the sequence. Oblique imaging to distinguish between a uterine fibroid from an ovarian fibroma. All cystic masses with suspected solid elements should have a gadolinium enhanced T1 weighted sequence, and diffusion weighted imaging to identify peritoneal metastasis and recurrent disease. Dynamic contrast enhanced MRI allows a semi-quantitative study of lesion microvascularization. So clearly these sort of details, we have to consult an expert radiologist. I mean, I don't think mortals like us can handle all these things. And we are now going on to O-RADS MR. So we looked at O-RADS ultrasound, and now there's O-RADS MR also. Score 1, 2, 3, 4, and 5. 5 being the highest risk. Any lesion with a solid tissue and high risk uptake, and they have a different type 3 curve. And if there is no dynamic study, a solid tissue uptake greater than the myometrium, and so on, peritoneal carcinomatosis. So these are on MR, you have the scoring by the ovarian RADS system. Now, the Adnex MR can also be, both ultrasound and MR can be used for Adnex scoring, for O-RAD scoring. So here again, you have the Adnex score 1 to 5, and the features on MRI are listed on the right-hand side. Again, comparison of various MR strategies. You have the Adnex MR score, the O-RADS MRI category, and the non-contrast MRI score, or the conventional MRI. And all of them have very high areas under the curve. So the conventional MRI has 93% area under the curve. The MRI, 96%. The Adnex MR is 96 to 98. So very, very similar. But probably the Adnex MR score is probably the better one. Now the area under the curve really reflects the accuracy of the test. Again, this is a slide to compare ultrasound and MRI. So Like I said, ultrasound is first-line imaging, whereas MRI, the primary role is problem-solving for indeterminate masses. The overall accuracy for ultrasound is good to moderate using standardized models when we use ADNEX or O-RADS. And MRI also very highly accurate and superior to ultrasound for difficult cases. Now, the weaknesses are that ultrasound is operator dependent and lower specificity for indeterminate lesions. And MRI, more expensive, less accessible, requires contrast for optimal characterization. The reporting systems could be IOTA models or O-RADS. And the decision making with ultrasound, it guides initial management and indicates need for advanced imaging. Whereas MRI, it confirms whether it's benign or highly suspicious of malignancy to guide surgical planning. Now, what are the clinical implications? A structured multi-step imaging approach is optimal for evaluating the adnexal mass. Initial ultrasound should be TVS, TAS using a standardized reporting system like the IOTA, ADNEX or O-RADS. Referral for MRI. Masses that remain indeterminate after ultrasound or those with features of malignancy should be referred for MRI. Definitely MRI or CT scan should not be done as the first step. This increases the diagnostic confidence. Referral to oncology, patients with a high probability of malignancy based on ultrasound and MRI findings to a specialized center. Now, a little bit on the management of an adnexal mass. If it is small, asymptomatic, a simple cyst, you can just observe, follow up with ultrasound after 6 to 12 months. If it's a large, symptomatic, benign mass, then maybe laparoscopic or robotic surgery, or if you don't have endoscopy, then open surgery with decompression within a bag if you're doing endoscopic. And if fertility is desired, of course, we preserve fertility, can just do a cystectomy. Frozen section could be done if we are not very sure. During pregnancy, observation, if small or torsion is unlikely, the risks and benefits of surgery should be weighed in view of the fetus. And if surgery is necessary, laparoscopy may be preferred. And you may need to tilt the patient to the side or change the position to make the visualization better. If it's likely malignant, laparotomy. Avoid laparoscopy if it's a complex mass or tumor markers are high. That's a rule that I follow very strictly. Especially in the postmenopausal women, if it's a complex mass, even if the tumor markers are normal or borderline, I would do a laparotomy. Take-home messages. The goals of evaluation are to determine the nature and origin of the mass and decide on management. A good history and clinical examination is where we start. It is a must. Ultrasound scan will give a lot of information and should be the primary modality of imaging. If you are a general practitioner, family practitioner, or a general gynecologist, know when to refer a suspicious mass. And if malignancy is suspected, CT, MRI, and tumor markers will help. And sometimes I see that only CA125 is sent. In a patient who is less than 40, we have to send germ cell markers. Sometimes I see germ cell markers sent for postmenopausal women, not necessary. So usually very rare to find germ cell tumors above the age of 40. Avoid laparoscopy and spill of tumor in suspicious masses. So I thank you for your patient hearing. These are the institutions I worked in. The top left is Narubi, where I work now, and the motto there is efficient and ethical care. The bottom left is CMC, where I've worked more than 35 years, not to be served, but to serve. And the top right is in Muscat, a new cancer center, where I helped start the department. And of course, right bottom is Velo Fort, which many of you have visited. Thank you so much.
It was a great presentation, Abraham sir. We thoroughly enjoyed it. And persons, your comments on this?
Say that again.
Hello.
There's a lot of background. Yeah, not clear, I think, the whoever is asking question.
Hello, Lakshmi madam, your comments?
That is really an exhaustive coverage of the topic, Abby. And I think certain points I think have been certainly clarified, that we should start with imaging and then move on. And especially even by imaging, I mean simple plain ultrasonography, and don't start with an MRI or a CT and wonder what to do. And of course, you have told us all about the various Roma, ROCA, all the algorithms. I have my questions, which I will reserve for the time being, and we'll let the audience ask. Yes, Padma, any? Is there anyone? Are they asking the questions? Are they putting it up in the chat, or what is the way you want us to do it?
As of now, I don't see any questions in the chat box. So probably, madam, you can just go ahead.
I'll wait for Vani for her comments. Vani, what do you think? What do you have to say?
Oh,
yes.
A stream of information. Very well done. Within a short span of time, is really given almost everything A to Z. Thank you very much. It was nice, lovely listening to. Of course, we are sitting, we are private practitioners, sitting outside, seeing cases, and all of us have an ultrasound scan. And mostly, yes, a good sonologist gives us a clue. Most probably it is intermediate or malignant. The only thing always I fight with the oncologist is, I always send for MRI, because all of us say, ultrasound scan followed by MRI. And then with MRI, when she goes to the oncologist, he will always ask for a CT. And he says, our oncologist, he says, he prefers everywhere, wherever I see Adnexal mass, they suggest a vaginal scan followed by MRI, a good MRI. He always insists on a CT. He says it's better than MRI in a case of ovarian malignancy, because he can also have a look at any metastasis outside clearly, especially an abdominal metastasis. Even a very small tumors, they can have an extensive metastasis. So that's it, and nothing else.
So what's your comment
Yes,
on
I
that?
take your point.
Yeah. Yeah.
No, I find, yes, and if they go to oncology, medical oncology, they'll ask for PET scan also. So it's quite sad that patients get multiple imaging modalities, but for the most part, you can manage with either CT or MRI. MRI is a little better for soft tissue if you want, especially if you want to see whether there's any infiltration to bowel and things like that. That's probably better. But CT works very well for upper abdomen and lymph nodes and all that. So also the cost factor. At least in Narubi, the CT scan is at 3,000 or 4,000 cheaper than MRI. So many times, yes, I would do a CT scan and not an MRI when I'm fairly sure it is.
The question is, if the person has an MRI, would you still ask for a CT? That is what Dr. Vani was referring to. That
I wouldn't.
They prefer a CT to
not.
an MRI. Is that right, Vani?
I would not.
What?
No.
Okay.
No. There are two aspects. One, straight away he asks for MRI, because, and even after MRI, if at all he wants to take knife in his hand, he says, I want to know whether there is any metastasis inside the abdomen. He says with all peristaltic movement and bowels, it's very difficult for MRI to pick up early. So this is CT will give me a clear picture whether how to go about it. I can have a clear picture as how to go ahead with surgery.
I would look at it this way. I mean, if it's not going to change management, I wouldn't do it. If I'm fairly certain that I can remove most of the tumor and I'm going to operate, I will have the best result is when I look inside. If all the CT, MRI, I've seen the reports, they are quite off the mark sometimes. So if I'm decided to operate, then I wouldn't waste the patient's money doing one more imaging. But yes, there may be a situation where you want to clarify something, you may need both CT and MR, but most of the time we can manage with either one.
Okay.
It's either one.
Yeah, given a choice between CT and MR for an ovarian cancer, I personally would prefer an MR. What would you prefer? What would you prefer, Dr. Abraham?
Well, I usually ask for a CT scan.
Okay.
It's the radiologists who like the MR,
No,
because
I'm not
they
taking
have
the
got
cost
this MR
factor.
Yeah.
No
Yeah.
cost factor.
No, because they have the MR, ADNEX reporting, MR, O-RADS, so that they have geared for the MR, ultrasound and MR. They won't talk about CT for differentiating the ovarian masses. So to differentiate an adnexal mass, the exact type of adnexal mass, whether it's malignant, benign, radiologists like MR. But as a surgeon, I feel I'm quite okay with the CT. But
okay.
Yeah, this is what I wanted to just ask, because always our like oncologists ask for CT. He says get a CT done and send, ma'am.
No, Vani, I was just thinking, I mean, what I'm asking Abraham is, if you're going to operate and you want information, I would prefer an MRI to CT. That is the answer I mean, what would you prefer if you are given a choice between this and that? For an advanced malignancy, I'm not talking about diagnosis. You know, it's an advanced malignancy, you need to operate. Yes. Dr. Abraham, what would you prefer?
like I said, I would prefer a CT. One thing I'm better at reading CTs. Maybe that's I find it more difficult to read MR.
Okay. Fine. Thanks.
I like to look at it. I mean, you need to look at the images yourself. Of course, you need to go and sit with the radiologist and go through everything. So if it's a MR, I definitely go with sit with the radiologist and go through each slice. Yeah.
Okay. There's somebody who's asked, one patient with a 2-centimeter mass in one Adnexal, 13-year normal ultrasound MRI CA-125 came 2 years with full-blown malignancy. How should one proceed? The woman, she's a 13-year-old girl, I think, who had a 2-centimeter mass.
Okay, I mean, a very unfortunate story that we would this patient should have been followed up. I mean, if it was considered benign or not so suspicious initially, patient should have been followed up in 6 to 8 weeks or 3 months or 6 months or whatever, depending on the degree of suspicion. And of course, the tumor markers would have given a clue.
No, CA-125 is normal. CA-125
but what about the germ cell? It must be most probably a germ cell tumor.
Absolutely. I think that's what
that's what I said. No, people ask for CA-125 in all age groups and don't ask germ cell markers. Or they ask for germ cell markers in older women when it's not necessary. So in this age group, all germ cell markers should have been done. So sometimes you find that HCT is left out or alpha fetoprotein is left out. Somehow people are referred, or when they come to you, they find that 1 or 2 markers are done and some of them are not done. So I think all the germ cell markers should be done.
Yeah, there's somebody else.
So what is the final histology? Final histology was?
I don't know. The person has not commented on that. Full-blown malignancy and Mets is what she has said. Okay. And
I mean, most probably a germ cell tumor which would respond fairly well for chemotherapy. So,
yeah. My question is, we've talked about a whole lot of algorithms, the AROCA, the ROMA, those which have the CA-125, HE4, etc. But finally, we are saying, let us look at the ultrasonography, ADNEX model, IOTA, O-RADS, MRI. So the algorithms have actually gone out of the window. Is that what you are saying? Because
yes, they started off with RMI, ROMA, ROCA. So with time, we are now sitting at ADNEX and O-RADS, which seem to be the best. So ADNEX ultrasound or ADNEX MR or O-RADS ultrasound, O-RADS MR would be the best. Instead of, but in the periphery, when you don't have a good MRI or good ultrasound, then we have to still use RMI and ROMA or whatever.
Okay.
But in a higher center, it would be only ADNEX.
ADNEX. ROCA, anyway, the UK trial showed that it hasn't made a difference to the prognosis, the 16-year follow-up, right? But RMI, I thought, was of some use when you're dealing with the kind of a borderline size or features, mass in the perimenopausal or postmenopausal. That's only
still got a place. It still has a use.
Yeah, RMI has some place. The other thing I was wondering is there is this international ISOUG guideline or ISUG that you do an O-RADS, but the O-RADS should be done by people who are certified in that. I don't think O-RADS is for the usual person who does an ultrasonography. Many of us gynecologists do ultrasound, and I don't think if we are not trained in it, we shouldn't be going about doing it. And a reliable O-RADS will tell you when to refer, when not to refer. If it is 3, if a score is 4 and 5, it has to go, the patient has to go to the oncologist and let them do that next model Let them do MRI
Yeah.
or CT. It is really not,
Sure.
and then they decide. Whereas if it is 1 or 2 or even 3, I think the generalist can manage. Would you agree with that?
Yes, definitely. And I think, needless to say, the quality of everything counts. I mean, if the quality is poor to begin with, then nothing will work. We can talk of ADNEX and the PET scan and MRI scan, but if the quality is poor, people come from outside CT scan, MRI scan, where radiologists can't really make out anything much. So really, quality is, of course, prime importance.
Yeah. So your recommendation to those who work and practice in the periphery would be, if he's got somebody with a score of 4 or 5 or features of malignancy, refer and finish with it and not get into trouble.
Yes.
This is what I keep on saying. Do not, okay. Maybe there was also one sentence in your one of your slides saying, if it is suspicious of malignancy, do not do a laparoscopy. I think you need to tell us why, because the younger generation has to understand why.
Well, laparoscopy, if it is small and you can put it in a bag and sure it won't spill anything, then it may be okay. So you need to be, people go for a 1-week training, 2-week training and call themselves laparoscopic surgeons. It's not done. Whereas in a referral center, we see patients who have had laparoscopy and they'll come with nice videos of the cyst being opened and spilt and everything. And within 3 months, the entire abdomen is full of tumor. And same thing goes with laparoscopic myomectomies, where it turns out to be a leiomyosarcoma. So I think endoscopy has to be really, you have to think very, very hard before you do endoscopy when there is a suspicious or a suspect malignancy. When it could be a malignancy, better not to do this unless you are a real expert who can do it in a bag and not spill anything.
And also do some retroperitoneal node along with that, because if you're going to do it, you need to stage it as well.
Correct. Yes.
Because these incompletely staged tumors that come to us later are the major issue when you try to manage them subsequently. Yeah. Okay.
Especially if it is spill.
Yes, especially if there is a spill. Vani, others, are there any more questions?
Actually, this is what I wanted, sir, to emphasize on. Because as you said, many of them, they like to do any cyst, adnexal cyst through the laparoscope. Patient also prefers it. And especially when it comes to infertility, people at 40, 42, sometimes they present themselves for IVF treatments and other things. And when they see an adnexal mass, they try to remove it before posting the patient for an IVF ICSI and other things. So, as Madam had rightly said, we need to give a clear guidelines for our viewers or our delegates here, like which are the cases we will be tackling it laparoscopically and which we should not be taking it laparoscopically. And even malignancy also sometimes, we are finding it difficult to take a sample. Even if the patient comes with an ascites, sometimes repeated tappings and then trying to separate the cells, it doesn't work out. And when we try to do a, needle biopsy, and this is another thing, sir, we have to talk about, because once they see a solid lesion, people like to put in a needle and take a sample. And with the spillage, there's an upstaging of the disease. So I just want you to make a few more comments on that.
Yeah, general dictum is not to put in a needle onto a suspicious ovarian mass or open it out during endoscopy. And if we have decided on chemotherapy, then of course the medical oncologist will want a biopsy. So like you said, ascitic fluid, we can centrifuge it and do a cell block, but sometimes you don't get the results on the cell block. So then you might have to do better to do an omental biopsy or a peritoneal biopsy, sometimes even a laparoscopic biopsy rather than sticking needles in. And you might get ascites draining from that site or some implant at the where you have gone in. So, but sometimes they say anyway it is disseminated, there's tumor everywhere, so they have to get a biopsy, so they may do a biopsy from somewhere accessible site.
Sir, I have a question.
I think
Sir,
yes.
In endometriosis, sometimes you get endometriotic cancer. In endometriosis, ovarian endometriosis. So how do you differentiate in MRI, sir? In severe endometriosis.
Only if If there is malignancy, there may be some nodule or some increased vascularity inside or something. There will be some suspicious feature.
Okay.
The risk of malignancy in endometrioma is less than 1%, but yes, it could get sometimes. But MRI should, that's better. The MRI is better than CT here to try and see the small nodule or small thickening of the wall or increase in vascularity and things like that. And of course, the CA125 may be high, but if it's very high, then again, better be careful.
Okay.
Another question, sir. Like, what group of people, when they come with even a malignancy, you would prefer fertility sparing treatment?
See, borderline ovarian tumors, we can do cystectomies. And germ cell tumors, we can do fertility sparing, even if it is advanced stage. Epithelial tumors, if it is more than stage 1C, then there's really no role for fertility sparing.
So all borderline tumors, irrespective of the stage, we can offer fertility sparing. That's what you.
If fertility is desired, if they have completed the family, then that's different.
And for germ cell tumors, even if they are advanced, then it is always correctable by giving a chemotherapy. So we don't have to be very aggressive, isn't it?
Yes, except for maybe an advanced, some very, what shall I say, one of those teratomas, malignant teratomas, etc. But even they are very chemosensitive. That is the advantage of a germ cell tumor, right? Yeah, even node positive, even supraclavicular node positive, we have actually managed with conservatively. Patient has conceived and
before chemotherapy, they preserve their ovum, right? Ovum pickup is done and they preserve it. For such,
if there is a normal ovary, if there's normal ovary on one side, yes, that can be done.
Usually nowadays, no, because IVF has come, invariably they do that. They keep it preserved.
Yes, all these young patients really need to see a reproductive endocrinologist before you start the chemotherapy.
And Taxol platinum combination is not as ovarian toxic as alkylating agents, right? And so, and also germ cell tumors, we give a different combination. Again, they are not really ovarian toxic. We have had pregnancies without any of this preservation, etc., etc. But of course, they can meet the.
Yeah, sometimes they downregulate ovaries by giving GnRH analogs. I'm not sure how useful that is, but yeah, sometimes we do that. But ideally, they're supposed to see the reproductive endocrinologist and see whether any ovum oocyte preservation is possible or an embryo preservation.
Actually, these ovarian malignancies are notorious. They're horrible. Once we diagnose, especially in the after the age of 40, 50, we are sure that the mortality rate is quite high. So early, without meddling, even when we have a suspicion, as Dr. Lakshmi has said, we have to refer them to the appropriate person. Not meddling outside, doing this, that. They have to go straight, even to confirm the diagnosis that this is this. I think they have to go to the oncologist. That way we are doing great service to that particular patient. That's all. Because invariably they undergo so many procedures outside and then they land up. Even today.
Somebody has asked a question. Can we, sorry, please. Go ahead.
No. I was just going to say that, somehow in some practices, we don't want to refer. You're frightened that the patient is going to go away from you. But we always have to keep the patient's interest uppermost and do what is best for the patient.
There's a question.
Yes, Dr. Lakshmi, you were saying something.
Yeah, there's a question here saying, can we do ovum preservation in a patient of germ cell tumor, considering that germ cell itself is a source of malignancy, even if the other ovary is normal?
I will pass the question on to the CTS. Yeah.
I think it's absolutely fine. I mean, some germ cells in a particular ovary might have turned malignant. It doesn't mean that you cannot cryopreserve or that the patient cannot conceive. We have I even remember the names of the patient and the face of the patient, the one who has had advanced malignancy and conceived subsequently. just a bunch of cells, germ cells that turn malignant and does not affect all the germ cells in both ovaries. So I think it's absolutely
if there
fine.
is normal ovary on the other side, normal ovarian tissue, definitely you can. Yeah.
Yes, you can cryopreserve, and they can also.
If both ovaries have got a mass, then it's a problem. Then maybe think twice. But even then, I don't know.
Yeah.
So discussion.
So before we conclude, I just want to make a comment that for the youngsters especially, don't be put off by the various criteria for Adnex model and what is it, IOTA, LS, LR1, LR2. They are very, what shall I say? It's not possible for any one of us to remember the whole thing. And it is not your business. Please do not try to remember any of this. They are all there, but they are for the ultrasonologists, those who are doing the imaging. They are for the radiologists. You look at the clinical risk factors. You look at the family history. You feel the mass and see, does it look malignant or benign? Does it have a particular characteristic? Does it tell you that it's an endometrioma or an inflammatory mass, and therefore you can manage? And of course, do an ultrasonography, and this you should get done by an expert ultrasonologist who will be able to give you some kind of an O-RADS scoring. And once you have got that, if it is absolutely or totally, certainly benign, you manage. If there is a suspicion of malignancy, you refer. There is no need for, if you're just a practicing general gynecologist and not an oncologist, you don't have to break your head trying to remember all this. But only remember that if it is suspicious of malignancy, refer, and refer. Do not put in that scope. Please resist. This is what I would advise. AB, agreed?
100%, ma'am. That's why I started off by this clinical features and the ultrasound pattern recognition. I think that's most important for the first level. And all these other things, like you rightly said, are for the expert radiologist or sonologist. And in an academic situation, yes, we need to be aware of these things, but for the most part, we really have to go by the clinical history findings and the ultrasound imaging to decide whether we can manage it or whether we need to refer. You are 100% right, man.
Thank you.
And you put it very well. You concluded very well. So
Vani ma'am, any more comments?
It was a very interesting session, because very nice to hear. After a long time sitting like this and listening to a real A to Z about Adnexal mass, especially malignant, very nice. Lovely.
Both the super teachers, Dr. Abraham and Dr. Lakshmi Seshadri madam, and of course Dr. Vani madam. The session very interesting with your presentation, sir. It was really awesome. And the chairpersons with very interesting inputs and queries which were raised. And I think if there is no more queries, can we call it a day and end the session?
Yes, ma'am.
Radhika?
Yes, ma'am. Yes, ma'am. Wonderful webinar, ma'am.
Yeah. Thank you.
Many of them have joined. Thank you so much, ma'am.
Yeah. Thank you. I wish you all of you have a nice evening.
Thank you, ma'am.
Yeah.